Hello everyone. Today we'll be discussing the topic about drugs used to treat bacterial infections. Antimicrobial resistance. Within 10 years of Fleming's discovery, Group A streptococci and pneumococci had developed modes of resistance. Antibiotic resistance has continued. Penicillin resistance became widespread in the 1950s and 1960s, and outbreaks of resistant gram-negative organisms and beta-lactamase-producing bacteria occurred in the 1970s. Factors that contribute to this phenomenon include increasing populations of immunocompromised patients, increases in the number and complexity of invasive medical procedures, and increased survival of patients with chronic diseases. Spread of resistant organisms in the community has been associated with daycare for young children, overcrowding, travel, and the use of antibiotics in agriculture. The leading risk factors for having a drug-resistant pathogen include recent use of antibiotics, age younger than 2 years or older than 65 years, daycare center attendance, exposure to young children, multiple medical comorbidities, recent hospitalization, and immunosuppression. Every antibiotic class has resistant organisms. Local resistance patterns can be identified by monitoring the antibiogram of the local laboratory. Vaccination with pneumococcal vaccine has decreased resistance. Core elements of antibiotic stewardship. Commitment. Demonstrate dedication to and accountability for optimizing antibiotic prescribing and patient safety. Action for policy and practice. Implement at least one policy or practice to improve antibiotic prescribing, assess whether it is working, and modify as needed. Tracking and reporting. Monitor antibiotic prescribing practices and offer regular feedback to clinicians or have clinicians assess their own antibiotic prescribing practices themselves. Education and expertise. Provide educational resources to clinicians and patients on antibiotic prescribing and ensure access to needed expertise on optimizing antibiotic prescribing. Penicillins. Pharmacodynamics. Penicillins hinder bacterial growth by inhibiting the biosynthesis of a bacterial cell wall mucopeptide, also called murin or peptidoglycan. Penicillin. There are only 4 natural penicillins that are commercially available. Penicillin 5 is administered orally. Procaine penicillin and benzathine penicillin are administered intramuscularly, and penicillin G is administered intravenously. This group is active against aerobic gram-positive organisms, including Streptococcus species such as S. pneumoniae and Group A beta-hemolytic Streptococcus, also known as GABHS, some Enterococcus strains, and some non-penicillinase-producing Staphylococci. Aminopenicillins. Like penicillin, aminopenicillins have reliable activity against gram-positive organisms, including Streptococcus and Enterococcus species. However, they have greater activity against gram-negative bacteria because of their enhanced ability to penetrate the outer membrane of these organisms. Ampicillin and amoxicillin are the only 2 available aminopenicillins. Although beta-lactamase inhibitors also contain a beta-lactam ring, they have poor antimicrobial activity alone. As combination products, ampicillin/sulbactam and amoxicillin/clavulane have excellent activity against methicillin-susceptible Staphylococcus aureus, also known as MSSA. Streptococcus and Enterococcus species, Moraxella, Cataralis, Haemophilus influenzae, Neisseria, Meningitis, Salmonella, some Shigella species, Pastorella, Multocida, Actinomyces, Clostridium, Peptidostreptococcus, Bacteroides, Fragilis. Pharmacokinetics. Although oral penicillin formulations are generally well absorbed from the gastrointestinal tract, use is limited to mild to moderate infections because higher than recommended doses cause GI distress and diarrhea. Penicillins are bound to plasma proteins to varying degrees and are well distributed to most tissues and body fluids. Excluding nafcillin and oxacillin, penicillins undergo negligible metabolism and are excreted primarily as unchanged drugs in the urine, achieving high urinary concentrations. 90% of the renal excretion of penicillin is by active tubular secretion, and most other penicillins undergo extensive tubular secretion. Probenecid, which competes with penicillins for the tubular secretion carrier, will prolong the half-life and raise the peak plasma concentration of penicillins. Adverse drug reactions may cause serious immediate allergic reactions. Reactions occur within 2 to 3 minutes of administration. Patients may be given desensitization therapy. Rash. Maculopapular rash occurs 9% of time, is not allergic in origin, and appears 7 to 10 days into treatment. GI. Diarrhea, nausea, vomiting, addition of clavulanae increases risk of diarrhea. Fungal overgrowth. Clostridium difficile colitis. Most are pregnancy category B. Clinical use and dosing. Commonly prescribed for infections seen in primary care. Amoxicillin. First-line therapy for acute otitis media, also known as AOM. And sinusitis. PCN. Used for streptococcal pharyngitis. Amoxicillin/clavulanae, first-line therapy for infection following bites, including human bites. If antibiotics are deemed necessary, empirical selection or definitive, culture-derived selection are both appropriate strategies. Monitoring. Both microbiological and clinical responses are used to evaluate the therapeutic outcome of antimicrobial therapy. For most infections treated in outpatient settings, it is sufficient to monitor clinical response alone. Local signs of heat, redness, swelling, tenderness, or discharge usually abate after 48 to 72 hours. Patient education, administration. They should understand that failure to complete therapy may result in resistant infections that can be passed on to family and friends or cause the patient to become more seriously ill. Doses of the medication should be spaced out as evenly as possible, without sleep disruption throughout the day. Missed doses should be taken as soon as they are remembered, but the dose should not be doubled. Adverse reactions. Patients should be taught to distinguish allergic reactions from other adverse effects so they can provide an accurate drug allergy history. Cephalosporins are beta-lactam antibiotics structurally and chemically related to the penicillins. Cephalosporins inhibit mucopeptide synthesis in the bacterial cell wall, making the bacterium osmotically unstable. 4 generations. First generation, used for skin and soft tissue infections, primarily active against gram-positive bacteria. S. aureus and S. epidermidis. Second generation, active against same as first generation. Plus Klebsiella, Proteus, and E. coli. Third generation, used for broader indications, more active against gram-negative bacteria. Fourth generation, resistant to beta-lactamase, primarily active against gram-positive bacteria. 5th generation, ceftaroline, similar to 3rd generation except active against MRSA. Pharmacokinetics, oral formulations absorbed from GI tract, widely distributed to most tissues, some highly bound to proteins, some are metabolized to less active compounds. Most are excreted via kidneys in various degrees as unchanged drug. Adverse drug reactions, allergies, skin rashes, arthralgia, coagulation abnormalities, anemia, neutropenia, leukopenia, thrombocytosis, fever, seizures, and renal/hepatic failure. Clinical use and dosing. Used for therapeutic failure in AOM. 1st generation, streptococcal pharyngitis and skin infections. Cephalexin, cefpodoxime, and cefixime can be prescribed as second-line drugs for urinary tract infection. Ceftriaxone and cefixime can be used for general condition in gonococcus/chlamydia infection. Cefpodoxime, cefuroxime, or parenteral ceftriaxone, followed by oral cefpodoxime, used for community-acquired pneumonia. Monitoring. Monitoring for therapeutic and adverse responses to antimicrobials requires clinical, microbiological, and laboratory data. Because the cephalosporins have a broad spectrum, signs and symptoms of C. difficile infection, also known as CDI, as well as other superinfections should be noted. Diarrhea is common with some cephalosporins and must be distinguished from CDI. During prolonged therapy, periodic BUN and creatinine clearance should be determined to evaluate renal function. If the creatinine clearance indicates renal impairment, dosage should be decreased according to the schedule in the package insert or drug reference. Patient education. Emphasize to the patient or caregiver the importance of completing the entire course of antibiotic therapy. Hello everyone, today we'll be continuing the topic about drugs used to treat bacterial infections. The fluoroquinolones are synthetic broad-spectrum antibiotics chemically related to the quinolone naldixic acid, with the brand name being Negram, a narrow-spectrum antibiotic used to treat UTIs. Pharmacodynamics. Fluoroquinolones are bactericidal through interference with enzymes required for the synthesis and repair of bacterial DNA. Spectrum activity. Fluoroquinolones are notable for their extensive gram-negative activity against E. coli, Klebsiella, Enterobacter, Campylobacter, Salmonella, Shigella, Proteus, Serratia, Haemophilus, N. gonorrhoeae, N. meningitis, and M. catarrhalis. Overuse of these agents has already eroded the utility of this group of drugs. Resistance has been documented in community-acquired isolates of Staphylococcus, Enterococcus, E. coli, and Pseudomonas, not recommended for children younger than 18 years of age. Pharmacokinetics. Well absorbed. Take on empty stomach for best absorption. Adverse drug reactions. Black box warning to avoid when less toxic alternatives available. Tendon rupture. Older adults at higher risk can have delayed onset, 120 days to months after administration. GI. Pseudomembranous colitis. Central nervous system. Sleep disorders, dizziness, and acidosis. Renal/hepatic failure. cardiovascular, angina and atrial flutter, increased risk of aortic aneurysm or dissection, should be avoided in pregnancy, not prescribed for children younger than 18 years of age. Clinical use and dosing. No longer first line because of resistance and adverse drug reactions. Complicated UTI, pyelonephritis infections, and chronic bacterial prostatitis, pneumonia/chronic bronchitis exacerbation, PCN-resistant S. pneumoniae, skin infections, bone/joint infections, complicated intra-abdominal and infectious diarrhea. Monitoring. Watch for prolonged use, electrocardiography in at-risk patients before prescribing. Moxifloxacin. Avoid alcohol use. Monitor for tendinitis/rupture. Patient education. Food delays absorption. Many drug interactions occur. Take with full glass of water. Drugs may cause dizziness. If tendon tenderness occurs, stop medication and notify provider. Clindamycin binds to the 50S subunit of the bacterial ribosome and suppresses protein synthesis. Susceptible organisms are primarily gram-positive. It is also effective against selected anaerobic pathogens. Clindamycin lacks clinically relevant activity against enterococci and gram-negative aerobic organisms. Oral administration of clindamycin results in complete absorption and it is not affected by gastric acid or food. It distributes to pleural and peritoneal fluids with high concentrations in bile and bone but poor CSF penetration. Adverse drug reactions. The main adverse reactions with this drug are GI-related, including nausea, vomiting, and a bitter or metallic taste. GI intolerance may be dose-limiting. The most serious is the risk for CDI. The providers should consider CDI in patients who present with diarrhea subsequent to administration of clindamycin, especially if the diarrhea involves 3 or more unformed stools per day and contains blood, pus, or mucus. Other adverse effects include dizziness, vertigo, headache, hypotension, and rare cardiac arrhythmias. Indicators of hepatic and renal dysfunction occasionally occur. Lincosamides, clindamycin, clinical use and dosing, first-line therapy for MRSA in some areas, infections in PCN allergic patients, drug-resistant Streptococcus pneumoniae infections, dental infections. Rational drug selection, considered second-line therapy, narrow spectrum of aerobic activity, first-line therapy in special populations, pregnant women and children. Monitoring. Stop medication if significant diarrhea occurs. Patient education. Finishing therapy. Adverse drug reactions. Diarrhea. The macrolides are another historically early antibiotic group. The prototype drug in this group, erythromycin, was discovered in 1952. Pharmacodynamics. This group of drugs reversibly binds to the P site of the 50S ribosomal subunit of susceptible organisms and may inhibit RNA-dependent protein synthesis by stimulating the dissociation of peptidyl tRNA from ribosomes. Erythromycin is inactivated by acid, and erythromycin base is marketed in acid-resistant, enteric-coated form to retard gastric inactivation. Cross-resistance is nearly complete between erythromycin and the other macrolides. The macrolides are well absorbed from the duodenum following oral administration. Food decreases the amount of absorption of azithromycin tablets by 23% and the suspension by 56%. These formulations should be taken on an empty stomach. Macrolides are partially metabolized by the liver, and the clarithromycin is converted to active metabolites. This class of drugs is excreted mainly unchanged in the bile. The drug is also excreted unchanged in urine in varying degrees. Erythromycin is heavily metabolized by cytochrome 3A4, which explains many of its drug interactions. Precautions and contraindications. Most are safe in pregnancy and children. Azithromycin may cause prolonged QT interval and torsades de pointes. Adverse drug reactions. Dose-related GI, nausea and vomiting, abdominal pain, cramping, and diarrhea. Skin, urticaria, bullous eruptions, eczema, and Stevens-Johnson syndrome. Drug interactions. Inhibitors of cytochrome 3A4. Clinical use and dosing. Drug of choice for community-acquired pneumonia, mycoplasma, chlamydia, pertussis, Helicobacter pylori infections, clarithromycin, and chronic bronchitis. Rational drug selection, often as alternatives for patients with PCN allergies. Increasing resistance, not appropriate for treating AOM or sinusitis. Monitoring. Because erythromycin and clarithromycin inhibit the metabolism of many drugs, observation for altered response to concurrent medications metabolized by cytochrome 3A4 is essential, beginning with the first dose and continuing for several half-lives of the drugs after they are discontinued. Individuals with a history of hearing loss may be at increased risk for further hearing loss, especially if they have hepatic or renal impairment and are taking high doses. Adverse reactions. Taking erythromycin with a full glass of water decreases the GI symptoms that are the most common adverse effects. Fidaxomicin. Fidaxomicin, with the brand name being Difficid, is a macrocyclic antibiotic currently classified as an 18-ring macrolide, which was approved by the FDA in 2011 for the treatment of CDI. Fidaxomicin binds to RNA polymerase and thus inhibits RNA synthesis. Fidaxomicin is bactericidal, as is its active metabolite. Fidaxomicin has activity primarily against Clostridium species, C. difficile in particular. Resistance to fidaxomicin is rare and is not related to resistance with other macrolides or other antibiotic classes. Fidaxomicin is pregnancy category B, but clinical trials in humans have not been conducted. Drug interactions. Fidaxomicin may have synergistic effects with rifampin or rifaximin. No antagonistic or enhanced effects have been noted with other medications. Fidaxomicin should only be used for CDI. Hello everyone. Today we'll be finishing up the topic about drugs used to treat bacterial infections. Deoxazilodones are inhibitors of bacterial ribosomal protein synthesis, but unlike other antibiotics, they stop the first step in synthesis, in which bacteria assemble ribosomes from their dissociated subunits. Linezolid is most effective against aerobic gram-positive bacteria. Although linezolid resistance is not widespread and considered uncommon, reports of resistance emerged as early as 2002. Clinical use and dosing. MRSA pneumonia, uncomplicated skin infections, and use less expensive drugs first. Patient counseling for all antibiotics include advice to complete the entire course of therapy, take the drug as prescribed on an evenly spaced schedule, and not double miss doses. Linezolid may be taken with or without food, but should be taken with a full glass of water. The main adverse reactions are diarrhea, headache, and nausea. Diarrhea should be reported to the healthcare provider. Blood, pus, or mucus in the stool may indicate a serious problem that requires treatment. Sulfonamides, trimethoprim, nitrofurantoin, and phosphomycin. Pharmacodynamics. Sulfonamides block folic acid synthesis. Trimethoprim inhibits DNA synthesis. Nitrofurantoin may inhibit acetyl coenzymes. Inhibit both gram-positive and gram-negative bacteria. E. coli, S. pyogenes, S. pneumoniae, H. influenzae, and some protozoa. Resistance an issue. Adverse drug reactions. GI, anorexia, nausea and vomiting, diarrhea, stomatitis, rashes, increased hypersensitivity reactions, and photosensitivity. Central nervous system, headache, dizziness, and drug interactions. Avoid in glucose 6-phosphate dehydrogenase, also known as G6PD deficiency. Use cautiously in renal impairment. Clinical use and dosing. Most commonly used in UTI infections. MRSA is susceptible in some areas. Rational drug selection. Low-cost alternative in children older than 2 months and in those with PCN allergies. Monitoring. Control and status if treating UTI. Long-term use. Check complete blood count. Chest X-ray in patients who develop a cough when on nitrofurantoin. Patient education. Finishing course. Adverse drug reactions and resistance. Patient counseling for all antimicrobials include advice to complete the entire course of therapy. Patients taking sulfonamides and trimethoprim or combinations containing these agents should be counseled to prevent photosensitivity or photoallergy reactions by wearing protective clothing and using sunscreens. The patient who develops a rash while taking these agents should discontinue the drug and contact the healthcare provider. Tetracyclines include a group of drugs with a common tetracycline nucleus structure and similar spectrum of activity. Tetracyclines inhibit protein synthesis by reversibly binding to the 30S subunit of the bacterial ribosome and preventing the addition of amino acids to growing peptides. This class is typically bacteriostatic but may be bactericidal against highly susceptible organisms. Tetracyclines are adequately but incompletely absorbed in the fasting state. There are types of patients for whom the tetracyclines should be prescribed cautiously, including those with renal impairment, those with hepatic impairment, pregnant women, lactating women, and children younger than 8 years. In addition, outdated tetracyclines should not be administered. Clinical use and dosing. Doxycycline is considered first-line therapy for C. trachomatis and uroplasma ureolyticum. Tetracycline and minocycline are used to treat P. acnes. Some H. pylori regimens include tetracycline. Rational drug selection. Doxycycline and minocycline can be taken with food. Oral dosing forms of tetracycline should be stored in a tightly closed container in a dry environment to avoid accelerated decomposition that might result in toxic constituents. Tetracycline should not be used during pregnancy and should be avoided in children younger than 8 years. Tetracyclines can cause phototoxicity, so sunlight and tanning lights should be avoided. Signs of superinfection that should be reported to the prescriber include hoarseness, glossitis, sore throat, dysplasia, or vaginal itch and discharge. Vancomycin is a tricyclic glycopeptide antibiotic that inhibits cell wall synthesis by binding firmly to the D-alanine terminus of nascent peptidoglycan pentapeptide. The end result is a weakened cell wall susceptible to lysis. The cell membrane is also damaged, contributing to the antibacterial effects. Vancomycin is bactericidal for gram-positive organisms. Absorption of vancomycin from the GI tract is poor, although clinically significant serum concentrations have occurred. When administered intravenously, onset of action is rapid. Vancomycin therapy has been associated with nephrotoxicity, presenting with increased serum creatinine and BUN. Risk factors for nephrotoxicity include the use of high-dose prolonged therapy, pre-existing renal dysfunction, and concomitant use of other nephrotoxins. If vancomycin is infused too quickly, the patient may develop red man syndrome, a flushing of the upper body, urticaria, pruritus, or rash. Clinical use and dosing. Serious gram-positive infections resistant to other medications. Oral vancomycin is used to treat C. difficile infection. Monitoring. Hearing and renal function. The oral solution can cause a bitter or unpleasant taste and mouth irritation and should be followed by a full glass of water. Oral vancomycin can be taken without regard to meals. Adverse reactions. Skin rashes may occur and, if serious, should be reported to the healthcare provider. Patients should report evidence of ototoxicity, such as loss of hearing, ringing, buzzing, or fullness in ears and dizziness. Neutropenia, such as chills, coughing, difficult breathing, sore throat, and fever. Or nephrotoxicity, such as altered frequency or amount of urine, nausea or vomiting, increased thirst, difficulty breathing, and weakness. Mycobacteria grow slowly and are relatively resistant to drugs that are largely dependent on how rapidly cells are dividing, have a lipid-rich cell wall relatively impermeable to many drugs, are usually intracellular and inaccessible to drugs that do not have good intracellular penetration, have the ability to go into a dormant state, easily develop resistance to any single drug. Antimicrobials. Pharmacodynamics. Isoniazid, also known as INH, and ethambutol inhibit synthesis of mycolic acids. Rifampin binds to the beta subunit of mycobacterial DNA-dependent RNA polymerase and inhibits RNA synthesis. Ethambutol inhibits synthesis of arabinogalactan, an essential component of mycobacterial cell walls. Resistance to monotherapy develops rapidly. Cross-resistance with INH and ethionamide. Pharmacokinetics, well absorbed orally. Metabolism of isoniazid highly variable and dependent on acetylator status. Adverse drug reactions. INH, peripheral neuropathy. INH, rifampin and pyrazinamide, hepatotoxicity. Ethambutol, optic neuritis. Streptomycin and capreomycin, ototoxicity. Rifabutin, neutropenia and thrombocytopenia. Drug interactions. Many drug interactions. Rifampin, an inducer of cytochrome 450 enzyme. Clinical use and dosing. Follow Centers for Disease Control and Prevention guidelines. Active TB requires 4-drug therapy. Preventive therapy includes INH. Rational drug selection. Follow CDC guidelines. Monitoring. Directly observed therapy. Patient education. Importance of taking medication daily. Reporting of adverse drug reactions.